Good morning, everybody. I'm very glad to be here today in the morning with you. And I really feel like Oprah Winfrey in the talk show. And as you can see, I wear this paillette jacket for the occasion. I think this is the right outfit to interview the stars of the red carpet, Imperio and restorative world. Yes, world, because we have from Italy, Filippo Graziani, from Pisa, our best periodontist, and from Seoul, Ki Tae-Hu, our restorative and prosto professor, and from Geneva, our Irina Seiler, our best European prostodontist colleague, and from Spain, our dear periodontist, Fabio Vignoletti. And we are together today with you to dream and to think about the future of new technology in our field. And I always think that we have to dream big, because if our dream did not scare us, they are not big enough. So today we want to dream. And I gave a look in the medicine field. And speaking about new technology in medicine, the first thing that on Google appears is about the precision medicine. And I would like to ask Filippo, since in Italy we recently organized a meeting that was regarding the precision medicine in periodontology. I would like to ask you, what do you think about the precision and the personalized medicine in perio treatment?
Well, you see, Martina, being a periodontist, it's all about patient. You don't treat millimeters, you don't treat gums, but you really treat a persona. And at the end of the story, in a way, it's an easy question. What I'm saying is that we've been growing up in perio, just trying to encapsulate patient characteristics in our diagnosis, in our prognosis, and our treatment. Now, there is an issue on diagnosis and an issue on prognosis. As you know, we came out just recently with the new classification, and we try really to bring up some values of the importance of the person within the diagnosis. Just to make it very simple, a very severe periodontitis will make such a difference in somebody that is smoking and has diabetes compared to somebody that is not doing it. Let alone the fact that somebody that has the same type of defect but is 20 years older might require a completely different treatment. So all these various aspects are actually now part of our diagnosis. The issue comes when you want to bring these characteristics in the next step, which is actually to make a prognostic value. Of course, we know nowadays which are the patients that will respond the less, but this is very broad. That actually just gives us an overall idea of how the patient could respond or not, but I think it's part of our routine treatment that we get surprises continuously. We treat diabetic patients that respond fantastically. You may do implants on smokers that actually are there after 15 years with no bone hesitation, so to speak. So the question is, what is missing really to try to solve the conundrum of what the patient can give us in the long run? When it comes really to what is precision medicine and personalized medicine, as you know, is requiring to bring up some information of the patient that you acquire through various outcomes that may have an impact not just on the disease but on the treatment itself. And whenever it comes this on perio, the first feeling is that we don't know that much. We know a lot, but we don't know that much. So I think when it comes to regeneration, because that's what we want to discuss today, I think it would be very much important to realize the impact more than of the personalized medicine, but in which way you can tailor your regeneration. So in which way you can make the regeneration the best possible treatment for that specific patient.
Yes, and I know that you are working a lot also in the treatment of non-conventional defects. So probably you are trying to change the old paradigm that is possible to treat only infrabony defect and non-crater-like defect.
Well, you said
something
we need to
in
dream
advance.
big, so
we need to dream big
we
today.
need to dream big. Now, let's face it, I know everybody's gonna hate me, but regenerating a vertical defect, it's not a complex.
It's too easy.
No,
it's too easy for
sorry.
you. Everybody can do it.
A vertical defect from a biological standpoint is a defect that wants to heal. has everything in order to heal. Has lots of stability of the blood clot, because at the end of the game, everything goes back to make a blood clot very stable. The way you cut, the way you put materials or not, is just making a space to have a blood clot that stays there. That would allow a possible regeneration. Now, we started to work on complex defect, which is not just forcation, it's horizontal and crater-like defects. These are the defects that makes the difference. You know, there is a lovely paper from India that defines the horizontal defect, the periodontal orphans. Because the 90% of the literature is on an intra-bony defect, but the 90% of the defects are actually horizontal. And of course, we need to modulate. You can't just open and put something. You need to modulate the healing, you need some wound healing enhancer, but you also need something to support. And in this regard, I think that if I would have the chance to customize the material, that would be fantastic.
And Filippo, what about the surgery? I mean, we have been working through the years looking for new surgical techniques, whereas you are now proposing a less invasive, flapless approach. Could you tell us?
Well, the thing of the flapless approach is once again, it's a dream, but this we need to put it in perspective. You do flapless as a starting point to reduce the need for surgery. So the aim is not to regenerate, the aim was just to increase the chance that your primary treatment is effective. But if I was a patient, I would like to be treated not even with a non-surgical treatment. I would like maybe to take a pill and having my gum growing back or my bone growing back. And I think we don't have to forget which is the end point. As much as, please don't register this, as much as I love to do surgery, but really, surgery is a tool. But non-surgical treatment was very effective, but once again, the aim was not to regenerate, was to reduce the need for surgery.
Well, I believe that non-surgical treatment, a flapless approach would be ideal for the patient. Biologically is also ideal in the sense that you have the most stable clot, the most protected clot. Although, if we go to, as you said, if it's a 3-wall intra-bony defect, of course that it can work. But if we move to another type of defect, more challenging, of course I think that we still have to investigate on other surgical procedures. I mean, we have to look in the research towards new approaches in order to stabilize more coronally the flaps, maybe no papilla incisions, but we still have to move forward in the surgical field, besides the biomaterials that I would like to comment a little bit on. If we're talking about the future, but I would like to go back to the past. I would like to go back to the past and start from the beginning. Do you remember Tony Melcher? No, he wrote periodontal regeneration, and he finished his famous paper in 1976, the review, saying that the surgical techniques that will allow the colonization of the wound by periodontal ligament cells will be this type of surgery will be a fruitful field for future research. That was 76. Now, 43 years later, I think that we have investigated a lot the surgical techniques. We still have to do something, but I'm very proud to say that most of the investigation has been written and developed in Italy. But now we are moving towards the cells, maybe, don't you think? Those cells that Tony Melcher wanted to modulate and to guide through guided tissue regeneration within the defect, nowadays the focus of research is to take these cells, harvest them from the periodontal ligament, and put them in a scaffold in order to
There is an issue, Fabio, here that concerns me. That's always the problem when the control treatment is very effective.
Yes,
which
of
is,
course.
the baseline is working anyway pretty good. How much do we have to pay and investigate to add a little delta? And I mean, this is fantastic from a, let's say, intellectual standpoint, but we need a blast. We don't just need an improvement.
No, no, of course. Of course, if we, oh no, please.
But I think the blast, don't you think the blast will be that you reduce the invasiveness for the patients, that you reduce the number of visits the patient have to come to, that you increase the predictability of what you're doing? I think this is where regeneration should go to today. And with the technology that we have, the 3D technology where we can foresee and plan the ideal shape and size of regeneration for this specific site, and the means that we can develop three-dimensional grafts exactly for these specific sites, I think this should be the aim where we should go to. Even if it costs some money in the future, it will reduce a lot the invasiveness and also the expenses for the patients.
Yes.
Of course, Elena, what Filippo was saying is that since a blood clot already functions, I mean, a blood clot gives an optimal result as compared to growth factors or melogenins in three-wall defects. You're saying the control is so good that we need to, it's such an expensive therapy, or that's your point, right?
No, the
but
point
we
is
have to
that
move to...
is the cost. Of course, I'm talking about periodontal regeneration because, as you know, I just think that that's the only thing that exists. But no, I'm not very much interested in bone per se. But what I'm saying is the cost of millimeters of attachment gain.
Of course.
That has a niche. How much do I have to pay to get 1 millimeter more when my conventional treatment can allows me already something?
What is your
when I
conventional
referred to
treatment?
the blast, I was referring, I mean, I would justify as a patient to pay 2,000 euros more if you solve the issue. But I don't want somebody to come to me and say, okay, we're going to have 0.9 millimeters of attachment gain more on average for that.
I believe in a challenging defect, like a supracrestal defect, that's where we have to work for.
Yes.
As you say, we have a scaffold, we have some cells that will be in office harvesting, and then we place it in the scaffold, and then we will be able, hopefully, to grow vertically on a tooth.
That would be
and
fantastic.
that would be, no, that's
Yes.
that's impossible that we want to look
With a
for.
personalized regeneration, just customized for your patient.
Exactly,
Would
and
be
for this
really
specific
great.
site.
For this specific site,
Yeah.
yes. But sometimes regeneration cannot work, or we have to extract a tooth for dental reason, for example, and we have to manage the socket. And I know you are a real expert on this field, and you can give us some new trend in the socket management or socket preservation.
Okay, but we could talk about some sockets that won't heal by itself. We've talked about blood clots and everything, but some sockets, I call it erratic heal sockets, that don't heal by itself spontaneously, whatever we do, even after thorough debridement, and then even if we...
So in that case, blood clot is not enough.
Well, sometimes there is a sclerotic lesion that forms around the chronic lesions, and the bone becomes really thickening. They become thickening, so you would have a compromised lesion with limited blood supply. So in those cases, I think those areas, we really need some kind of blast. We were talking about some boost that would help the stimulation. And we've had a couple area research in BMPs, but BMPs, we have a limitation in the cost, safety issues, also the supply issues. So I think it's going downfall a little bit. So we had the BMPs, Fabio was talking about stem cells, but I think we need a little bit more time to have it stabilized. So lately, accidentally, I have been using hyaluronic acid. It has a osteoconductive, osteoinductive effect, and also antiseptic effect. And accidentally in dogs, we were able to see more mineralized bone compared to the controls. So I think that's an area that should be developed. Tony Scullion is working on soft tissues with hyaluronic acid. So we have new materials coming up, really, and we need to do more research on that, but I think it will be promising. And also, it needs to be very cost effective too, I think, not just for us, but for the patients. They need to be able to afford it, and the company, the industry has to be, I think, very effective. So I think that could be one possibility, hyaluronic acid. Also some areas I think open healing technique is becoming a little common. So maybe in areas of soft tissue, can we speed up or accelerate soft tissue regeneration, epithelialization? I think a lot of researchers now with the fibroblast growth factor, I personally worked on EGF, epidermal growth factor. So I think with these molecules or near areas of research, I think maybe in the future we could accelerate soft tissue healing, and that could really help our regenerative properties. Maybe we could go from the closed approach to, or more of a lenient open approach maybe. That's easier for the public, for the GPs. So maybe in the future, I think it may shift that way.
I think we're waiting for these magic pills, you know, the pink one for the soft tissues and the white one for the bone, just to take and grow.
Exactly.
For this, I would pay 2,000, no problem.
Me too.
No surgeries, only pills.
He said something very important. You said something that I really appreciated. It comes back to indication, because, you know, as he said, there are some sockets that might not heal, which the issue is how can I foresee which are the ones that are interesting, that might need all of these. This is very much personalized medicine. Now, I don't know, because I am not a follower of reach preservation myself in terms of clinical research, whether you could easily stratify the indication for this or not.
Okay.
You need to change
To regenerate the microphone.
Yeah, exactly.
But this was the Seoul point of view. I would like to listen to the Spanish point of view about socket preservation. What are you looking for in the future?
Well, I totally agree in the sense that, well, socket preservation is, besides these exceptional type of sockets that won't heal, they will heal spontaneously. So we are, I don't say that we're done with socket preservation, of course, but it's a type of defect that is...
We can try to reduce as much as possible the resorption that we have.
The loss, the aesthetic loss of volume, I think, is a very important part of the normal healing.
Yes, and if it would be possible to reduce this kind of loss of soft and hard tissue during the spontaneous healing process will be a dream. We will reduce the number of soft tissue procedures.
The point is that that's a physiological resorption of the bone crest that happens after tooth extraction, and it's kind of difficult to cheat biology,
yes.
And go against nature. But again, I think we will have to go towards a scaffold and the famous triad of
osteogenic
cells,
I know you love it.
growth factors, and a scaffold. And we will have to work a lot on scaffolds. I think that CAD/CAM personalized medicine scaffolds that will have to take a part of this within a socket or within a vertical defect. That's to me is the future. The future must go towards a synthetic type of scaffold, I believe.
Yes, also
that would
to
be
the
ideal.
digital workflow and to the, let's say, 3D
development of any structure.
Yes.
That's true. I think we see this a lot in restorative dentistry, how we can increase the efficiency of what we do, how we can reduce the number of visits the patient have to, I would say, invest in a treatment only by planning very precisely in the digital environment all the procedures that we want to do. So just thinking of crown and bridge prosthodontics, you can plan the position of the implant in the virtual environment and then place the implant in a guided approach and then have the reconstruction already prefabricated and then reduce the number of sessions. And I see this, I would say, technology as a great advantage in regeneration procedures. Not only that it's personalized, but also that it's defect and site oriented. You can create a file of what you would like to regenerate on a screen. You can extract this file and you can transform it in a machine into something, either a regenerative material to regenerate bone in a specific shape. It can be a scaffold. It can be a bioprinted scaffold where cells are contained. So you really combine all the different aspects. But you already have the shape and you design the aesthetics of what you want already pre-operatively, and therefore the surgical intervention can be shortened, the invasiveness can be shortened, the access can be planned accordingly, and I see the same also on the soft tissue level. We can design the volume that we would like to have, and also when it comes to exposed roots, for example, the soft tissue outline that we would like to have, and then create it virtually, transfer it into a material that helps the biology, the own biology, to develop there.
It's amazing, but I'm not sure I will like it, because at the end you will have also a robotic surgeon, and you will not need our help during this procedure.
You always need an engineer behind. So.
Yes, I need to study engineering now.
No, but the issue that Irena was highlighting to become, tissues builders. That's actually quite interesting.
It's something amazing.
Then, the rest, we can discuss. These are tools, you can add cells or not, and the way you scaffold it. But to plan, and the planning, I think, is crucial. Yeah. Now we foresee
should be really
the end point. We don't try.
Yes, complex and multidisciplinary group.
You see,
planning.
The point is, if I dream of the future, I don't even think that we will invest so much time in planning anymore. We will now invest time to develop software to do this for us in the future. So you will receive a plan, you just have to approve it. So even your time for planning cases will be shortened. For this, in your private practice, you can plan much more cases. You can maybe perform surgeries faster. You don't even need a roboter, because a roboter may add to costs. You don't want to increase the costs. You want a personal relationship to your patients, but still you can increase the efficiency of the procedures and the predictability. I think this is what we aim for, because everything we have now, I think, has been nicely documented in numerous studies that it works. I think we have very good regenerative procedures available, even on the soft tissue level now. But is it predictable? Is it exactly what we want? Is it exactly delivering the shape and the volume that we want? And I think this can be improved.
Yeah. Well, and talking about soft tissues, we have here...
Yes, I would like to speak about soft
Yes,
tissues. Obviously, we cannot
I would like to
avoid this topic.
We're talking to one of the best periodontal plastic surgeon in Italy. So I would like to, maybe we can make some consideration, because I think this is wonderful. Of course, we build everything on a software, but then until the robot will come, we will have still to build up to use the scalpel and design our surgical procedure. And I think that we have to look forward to new approaches. I don't know if maybe in Bologna
I don't
you're
know if
thinking about...
we really have in mind some new surgical approaches, but we are probably more working on material, on new soft tissue alternatives to the connective tissue, because now we have very good alternative with very nice, good mechanical properties. But we still need to add some biological properties to the alternative material that we have. It could be a dream to add some cell into our collagen matrix, so we will have a scaffold with a kind of...
This would be something I would be scared of, on the other hand side, to receive something that contains cells.
But it's your cells.
No,
Well,
yes, for the health, you think for...
Somehow, what will these cells do?
tolerance.
Even if it's my cells there, they have to create something that is not there anymore.
But
So
amylogenin works
Yes.
already in the same way with cell, and it's something...
Well, once again, when you trigger a cell, you know where you start, but you don't know where you finish.
Yes.
Exactly.
That's the main issue. And I think the issue on safety, I mean, you tissue engineering people know more this than myself, that I'm more traditional in my regenerative approaches. But in a way, and do let me make this comment, this is not a criticism, but when I started, and it was 99 and I was 12, I remember we did all these studies on, beginning was PRP, then we started to add cells and so forth. So now it's nearly 20 years down the road. And the blast that I was asking for, I haven't seen it yet, which doesn't mean that it will happen next year. So I'm really wondering why it took so long and why haven't we done it yet? Which, once again, it doesn't mean that we're not going to do it in 6 months. It's just a curiosity. I'm asking this.
I believe we have problems with But several problems with
Not in life,
with
right?
cells
In
therapy.
real
No, of course. We're talking about, we can stay here for one day. But no, we have several issues that we need to take care of still. The carrier, for instance, we don't know which is the ideal carrier. How does it release the cells? This goes along with your concern about, can that be, is that safe? And that's the first aspect. Still, we see that in preclinical, it works. We have some, I would say, sometimes good results, sometimes promising results, sometimes very similar to control. But when we shift, you agree with me, I think, when we shift from preclinical to clinical, there is no translation. In periodontal regeneration, there is only one clinical trial using cell therapy from the periodontal ligament and from China, and they demonstrated no differences within the two treatments. So I agree with you. There's something that we are missing in the signaling of the cells that we have there, in the carrier. How long does they, let's say, behave in the wound? Then factors related maybe to the. We have performed a study on supracrestal defects, where we were, coronally advancing a lot the flaps on top of the caspids of the teeth. But after 2 weeks, the flaps, relapsed towards a more apical position, and that was the main limitation. We don't cheat biology, So these are the things that I think we're still missing. And so I go back to the still very important issue, that is the surgical technique, that we will need to look for something that will stay more corona.
Stay more corona.
I think it took a long time because it's sophisticated first and it's very complicated. So it took a long time for us to really understand the mechanism. And also there's a safety issue and also the ethical issues too. So if you're translating from a preclinical model to clinical model, it's a different entity. So yeah, I think the complex situation was an issue. But at the end, I think we need to do it because I think it's promising for the patient. We haven't talked about the healing time. I think if we could somehow mix the scaffold with this type of boost, we could decrease the healing time, and that will be a tremendous benefit for the patient. So yes, I think the complexity of it had to do with, the long time we took to get here.
So yes, probably we can say that in the future, we have to dream in order to reduce, in order to personalize as much as possible our treatment planning in terms of regeneration and restorative and prosthetic treatment, in order to reduce as much as possible the patient morbidity, the patient invasiveness.
And costs.
And costs, obviously, and costs. So I think we need to continue always, in order to improve our life and our job, to dream and dream as big as possible.
Yes.
And I think we can conclude and say ciao to our Facebook friends.
Ciao, Mama.
Thank you. Thank you.
Thank you very much.
Thank you very
Thank you
much.
very much.
You're welcome.
Thank you, Martina.
Great discussion.